Well, welcome back. I am Meredith Adams from the University of Minnesota, and I'll be joined by my co-moderator in this session, Jeff Sharon from UCSF. Today, we're going to hear some great presentations about the diagnosis and management of two vexing problems, tinnitus and dizziness. And we specifically want to congratulate Dr. Susan Ellspermann from the University of Michigan for her ANS Trainee Award. She is receiving this award given her great work entitled Intraoperative Electrocochleography Predicts Outcomes in Transmastoid and Middle Cranial Fossa Repair of Superior Semicircular Canal Dehiscence. So congratulations, Dr. Ellspermann, and we look forward to hearing from you. Just for some housekeeping, again, we ask each of our presenters to stick to 6 minutes. And for our audience, if you would please actually pose your questions to a specific talk, then we will be able to organize those to have a great discussion at the end. Thank you.
Hi, everyone. Thank you to the ANS for having me today. My name is Austin Chow, and I am a third-year medical student at the University of Pennsylvania. The work I'm presenting today is a systematic review of radiographic imaging techniques used for the diagnosis of pulsatile tinnitus. Thank you to my co-authors, Dr. Hua, Caitlin, Dr. Eliades, Dr. Ruckenstein, Dr. Bigelow, Dr. Chowdhury, and Dr. Brant for their support. And I have no disclosures. So pulsatile tinnitus is a clinical symptom described as a rhythmic sound coinciding with the patient's heartbeat, commonly because of a flow murmur due to some pathology causing non-laminar blood flow. Some of the more likely causes include vascular stenoses, AV fistulas, tumors, IIH, and various anatomic variants. On a full diagnostic workup, an underlying pathology is identified in around 70% of patients. However, due to the broad differential, many imaging modalities may be appropriate for a patient coming in with subjective PT. While different diagnostic algorithms have been proposed, no review currently exists in the literature of the diagnostic yield and the utility of this battery of different imaging modalities. So we performed a literature search of 3 databases, and out of over 1,000 articles, 17 met our inclusion criteria. Of these, 11 were retrospective studies, while 6 were prospective, and no RCTs were found. 5 studies evaluated the utility of an entire test battery. And lastly, note that most of the studies actually involved imaging being ordered at the discretion of the provider. And so the indications for imaging may vary between institutions. So given the variability in modalities used and the inclusion criteria, diagnostic yields ranged from 18.1% to 97.2% across studies. The results were then pooled by modality using random effects modeling. 2 examples of our forest plots are shown here. So CTA at the top, and then combined MRI, MRA at the bottom. We saw a moderate to high heterogeneity in these subgroups, ranging from a low of 30% in Doppler, and then a high of 89% in CT temporal bone. So on this slide, you can see the pooled yields by modality. And I just wanted to go through and sort of contextualize them. Starting with Doppler, you see that its yield, or its pooled yield, was at 21%, which is quite low, but of course the technique is very fast and cheap and can quickly pick up any carotid vessel wall pathology. For CT, the yield was 65%. Diagnoses made were primarily temporal bone pathologies, including bony dehiscence of vascular canals. CTA in our sample had the highest diagnostic yield at 86%, which is comparable to the multimodal subgroup at the bottom of the table, which came in at 78%, which included studies evaluating an entire test battery. And so CTA was best for identifying, obviously, vascular pathologies. Furthermore, the bone window CT reconstructions could be obtained from the CTA to diagnose bony pathologies, usually seen on CT temporal bone only. Similarly, MRI, MRA came in at 58%. Similarly, it's a powerful tool for vascular anatomy, also picked up soft tissue and intracranial masses. And lastly, DSA, we only had 2 studies that included DSA in the results, and primarily they were used in cases of a negative CTA or a negative MRA. And so this slide just summarizes those points. The heterogeneity in study design and criteria precluded a formal subgroup comparison. However, we used the pool data, the diagnoses made, and the studies that directly compared 2 modalities to formulate a diagnostic algorithm, with the goal of establishing strict clinical indications to increase yield. And so one of the first questions asked is arterial versus venous origin. So indications of venous pathology include extinction with jugular compression or head rotation, or a low pitch whirring quality to the symptoms. And so for those, we recommend CTAV for initial evaluation. Moseni from 2018 reported on 30 PT patients and found that CTA captured all the diagnoses made with CT temporal bone. For arterial pathology, some of the indications might be vascular bruit, a high-pitched pulsatility, or vascular risk factors. So for this, we would recommend carotid Doppler if it's a carotid bruit, and then CTA if the bruit is in the periauricular or orbital areas. Doppler, of course, has a very high specificity, but low sensitivity. Sai from 2016 found that 25 out of the 25 diagnoses made with Doppler were subsequently confirmed with other workup. But among the 52 patients they had with completely normal Doppler findings, 13 of those were eventually diagnosed and further workup. And so a negative Doppler should prompt further evaluation with CT angio. So we put together these recommendations into a diagnostic algorithm. There's some considerations here. If the provider suspects a middle ear mass or SSCD, then it would be most prudent to consider CT temporal bone for initial imaging. For patients with a normal clinical exam, which you can see on the right, CTA is an excellent choice. MRI, MRA could be considered as well if patient has, say, contrast allergy or a specific indication. Maddox's paper from 2008 similarly favors the use of CTA over MRA for initial imaging due to superior visualization of vasculature and also the ability to evaluate bony anatomy, as we discussed before. And so as the literature continues to mature, we would advocate for a minimum reporting standard for modality-specific diagnostic yields and outcomes. Departments that do utilize a consistent algorithm for workup will be better set up for collecting patient data to eventually evaluate its effectiveness. Of course, we'll need more prospective studies that can sort of eliminate that bias that's introduced by provider discretion for imaging. And that'll be very important for validating our proposed algorithm and continuing to improve diagnostic utility. Thank you very much.
Well, good afternoon, Ken Maxwell. I'm a neurotologist here in Winston-Salem, North Carolina. My pleasure to talk with you all today about a phase 1/2 study for OTO 313, which we used for acute tinnitus patients. I will move right through. I don't have any relationships to disclose. The gasocyclidine is the drug that we're using. It's an NMDA receptor antagonist, and this is data from rat studies and demonstrates a very potent selection for the receptor in blocking that. So this gasocyclidine is put in a gel form, or oil form essentially, and then used as an intratympanic injection. It was basically the PK data is there on the graph, and you can see that it has a pretty long activity, which is why that particular drug was chosen. So there were essentially an A and a B part to this. I'll really just cover the B part. So there was initial safety cohort of 8 patients that were done in one location. It was felt that there were no significant adverse events related to the treatment. And so then an exploratory cohort of 35 patients was then studied. So there were 31 that were evaluable at the end. We had 4 early terminations, not due to any kind of adverse event. They had persistent unilateral tinnitus of 6 months duration or less. We required a 25 score on the TFI, which is the Tinnitus Functional Index, and to be included in the study. There were some safety assessments done, which are listed, and then the efficacy assessments were the changes in TFI. There was a daily tinnitus loudness and annoyance rating that each patient did, and then patient global impression of change. It was just asking them, does it seem better? And then, so these were all recorded over 2 months. Day 15, 29, and 57 were the actual study dates. This patient demographics are here. Essentially, there's really no difference in the 2 groups. It's just included in for your edification, but both groups were about the same. The most important part of this actually is, well, what did it do? What's the results? And so our initial or most important, I guess, observation is the TFI. And so this tinnitus functional index is, of course, a 100-point scale, 25 questions. And you can see that the scores in the ODO-313 group show a decrease, which is an improvement in their overall TFI scores through the all days 15, 29, 57. Looking at the tinnitus loudness and annoyance, you can see that there are corresponding reductions in that as well. And the patient global impression of change followed these as well. Because this is really an efficacy patient-reported outcome and not powered statistically to find a statistical significance, we don't really don't really have that kind of data. Although a post hoc analysis, which you'll see, does show that if we had done statistical analysis, or if you could do that, we really don't have the numbers, but that it would show. So the responders are not all patients responded in either group, obviously. So we had 6 responders in the 313 group and 2 in the placebo group. And the bottom is the change in the TFI. And according to the Michael article, who really developed the TFI as an index for tinnitus studies, a change of 13 points or higher is considered significant or clinically meaningful. And so given those numbers, basically this is what it looks like. And it looks like there is an effect, a medication effect with this gacyclidine injection. So we looked at, obviously, problems related to this, and most of the adverse events are procedure related. Intratympanic injections are, I wouldn't say they're unpleasant for patients, but it is invasive. We do use a topical Emla cream and then an injection of 0.2 microliter injection, and it's really well tolerated, although there are patients that do have some pain, some discomfort associated with the injection. Some sense of blocking in the hearing or worsening of the tinnitus is quite common over that first week. There was one serious adverse event not related to the medication. It was a cardiomyopathy that developed during the 2 months after the treatment, and it's really not felt to be related to this at all. So it seemed very safe and well tolerated. And it was interesting that twice as many placebo patients actually complained of an emergent adverse effect than the actual investigational product. So the bottom line is we did a single intratympanic injection with gacyclidine, which is called ODO-313 for the Autonomy Company, which is who produced the medication. It was really well tolerated. There were a higher proportion of responders versus placebo, particularly at that 13-point clinical meaningful reduction in the TFI. The mean improvements from the TFI, the loudness and annoyance, and the PGIC were all correlated and all seemed to show this effect that lasted over the entire 2-month trial. So because it appears to have some effect, these findings then do tell us that we probably should look at this. And so the company is planning to do another study, this time with 140 patients, and to power it for statistical significance.
Good afternoon, folks, and I appreciate the ANS and the column allowing me to share this work with you on transtemporal sigmoid sinus decompression for idiopathic pulsatile tinnitus. Over a 15-year period, we did this procedure on 25 patients, and the results were 92% had complete or near complete resolution of their pulsatile tinnitus. Some of the keywords down here to follow are listed. Idiopathic pulsatile tinnitus really is not idiopathic until you rule out every possible cause. In our initial 7 patients, we did that with arteriograms, but going forward, we reserved the arteriogram or transvenous manometry for those that would have specific indications for AVM or arachnoid granulation causing compression of the sigmoid system. Felt that these studies were both unnecessary and also dangerous for the patient. We reviewed charts of 287 patients that presented with a primary complaint of pulsatile tinnitus, and we used the THI to evaluate them both pre and post-operatively, as well as at various points during the study. You can see on the left-hand side of the slide here how we evaluated the predominant group, most of the group, and CT, MRI, and MRV were our primary go-to, but we also did CTA. The medical therapies were based on the most likely cause of their pulsatile tinnitus. If they were resolved with those procedures or that medical therapy, then they were excluded from the study. Some of those most notable exclusions are obvious conductive hearing loss, sigmoid transverse sinus stenosis, and patients with suspected arteriovenous malformations. We did not exclude the patients that had sigmoid sinus anomalies such as dehiscence or excuse me, diverticulum, sorry, I'm blocking. We left those in the study and reviewed those ad hoc. The theory is that the predominant cause of idiopathic pulsatile tinnitus is from a non-laminar flow through the sigmoid sinus. Now, to be complete in this patient group, we decompress the sigmoid, the venous structure from the sinodural angle to the retrofacial air cells, and also up to as much as we could get, or as much as I could get on the jugular bulb, and decompress it both anterior and posterior to the sigmoid. The purpose for doing such a complete dissection is that the exact location of this turbulent flow is not known. And by doing this extensive decompression, we were going to get the most likely sources. 23 out of the 25 patients had complete resolution of the symptoms and a mean follow-up on these patients of 5.5 years. You can see the THI on the chart to your right, and they went from an average of 4.19 to 1.38. We also had 2 patients that were legitimately suicidal, and they responded appropriately and had complete resolution of their pulsatile tinnitus long-term. You can see predominantly in females as well as the right side. I think the female predominance is more associated with mild elevated intracranial hypertension associated with pulsatile tinnitus. Some of these patients might reach a level that might be considered intracranial hypertension, either mild or moderate. In our ad hoc review of the CT scans, we did find 5 anomalies, 5 diverticulum, and 2 of the patients that had diverticulum also had dehiscence. These were not specifically addressed during the procedure, and all of those patients had complete resolution of their pulsatile tinnitus without specific treatment, either compression or other type of coverage technique to their dehiscence or diverticulum. Here's a patient preoperatively with a diverticulum on the sigmoid in A, and then postoperatively B, where clearly we did not address the diverticulum, and this patient had complete resolution of her pulsatile tinnitus immediately postoperatively as well as long-term. The 2 patients that did not respond both had about 50% resolution of their pulsatile tinnitus immediately after surgery, and then returned back to their previous state. We're currently evaluating both of these. However, one had a VP shunt for severe headaches, although their LP opening pressure still remained around 25. The limitations. Although in the first 7 patients, which was our prospective study, we did a complete evaluation. The rest of them we did augment that to the most likely studies to yield fruit in our process. In conclusion, this was a highly effective procedure for people with diagnosed idiopathic pulsatile tinnitus, and it was effective in the patients that had sigmoid sinus wall anomalies without addressing the sigmoid sinus wall anomaly. I think there's a lot been written on the sigmoid sinus wall anomalies as a cause, mostly dehiscence. And the feeling is that when these patients have undergone surgical correction, be it covering or other type of augmentation, what they're actually doing is they're changing the flow status in the sigmoid sinus by the procedure that they're doing, either by the decompression to apply the covering or by the covering itself. I think it's not clear 100% that this shows that the sigmoid sinus wall dehiscence are not a cause, but I think this is highly suggestive that they're not the cause and that a full decompression is more adequate in control of their pulsatile tinnitus. Thank you.
Hi, good afternoon, everyone. My name is Eric Formeister, and I'm the first-year neurotology fellow at Johns Hopkins. I want to thank the ANS for the opportunity to discuss a project that I've been doing over the last couple of years, really on using a machine learning technique to try to predict common types of dizziness. I have no disclosures for this presentation. So what is machine learning? So I think a lot of us have heard about this recently in the media, and kind of more sort of germane to our specialty over the last couple of years. There's been a lot of publications coming out on its utility in analyzing databases. But I like this diagram because it tends to cluster the two main types of machine learning: the supervised type, where you know the answer, or you have the outcome of interest, and then you ask the model to come up with associations; and the unsupervised type, where it's just sort of a little bit more of a black box investigation. So for our study, we wanted to look at whether a large database essentially collected by the US Census Bureau of US adults in 2016 could be modeled with this decision tree approach to get at factors that could predict different types of common types of dizziness in the US population. So our rationale was this model, and really decision trees in general are ideally suited to large data sets to help identify factors that are important for an outcome of interest, especially when you're not exactly sure what those associations might be. Now, up front, I just want to say that the purpose of this study wasn't necessarily hypothesis driven, but more hypothesis generating, where we wanted to get an idea of what types of patterns would emerge from factors and variables in this data set that weren't germane to the actual dizziness sort of diagnosis in particular, meaning what types of functional decrements, what types of just sort of experiential factors did people identify in each different dizziness subtype. So we wanted to first describe how this is actually used and kind of sort of demystify a little bit of what this process entails, and then try to see if there were any types of important factors that we could identify that, again, weren't specific to dizziness symptoms alone. So we used the 2016 NHIS, which is used in particular because this is one of the most recent year that actually included a balance and dizziness supplement, which is about 150 additional questions. They don't do this every year, but when they do, it's sort of ripe for analyzing because it's a huge database, and it's very it's administered in a proper population cluster randomized setting. So from this response to various questions on this supplement, we generated case definitions for 6 common causes of dizziness, including vestibular migraine, BPPV, Meniere's disease, 3PD, superior canal dehiscence, and bilateral vestibular hypofunction. Then we applied what's called the gradient boosted decision tree model to try to predict each dizziness subtype. So this can be thought of functionally as a game of 20 questions where the model goes through each different factor and tries to come up with a predictive model of the subtype that you're interested in. Now, this model will actually give an importance factor, a relative importance of each of the factors that are included. And all of these sum to 1. So whatever you put into the model is included in the decision tree, but the ones that are closer to 1.0 in terms of its value are the ones that are more important for the model actually predicting that outcome. So, again, 33,000 adults, the one-year prevalence of dizziness is high at 17%. Vestibular migraine was the most common subtype at about 4%, followed by benign positional vertigo and the other subtypes seen here. How did the decision tree models perform? They actually performed quite well for classifying outcomes with an overall accuracy of 78 to 95%. So as an example, for vestibular migraine, I just want to show the raw data because I think anyone who's done this approach will be familiar with this type of output. But basically, this technique will train on about 80% of a big data set. And then based on what it's learned from that training portion, it'll apply that to the remaining 20% of the data. And then from that test set, the remaining 20%, it'll come up with a specificity, a sensitivity, and then what's called an F score, which is just essentially an average of the specificity and sensitivity, which for vestibular migraine was 82%. Likewise, for the other dizziness subtypes, they were all pretty high in terms of specificity, a little bit lower in sensitivity, and then overall accuracy for predicting each of these dizziness subtypes, again, using factors that aren't related to what you would use in clinically diagnosing a dizziness type at 86%. So for vestibular migraine, this output, again, is nice in that it gives you sort of the relative importance of each of the factors that was used in the model. And we found that severe fatigue, age, prior history of anxiety or depression treatment, and facial pain, interestingly, these were the most important factors in this model output for predicting vestibular migraine. So in discussion, there are a lot of discussion points about machine learning about this technique in general. So it's not a diagnostic tool. That was not the purpose of this study yet. But you could see that an extension of this might be useful in terms of handling or triaging people. It's really limited by its inability to provide p-values or odds ratios or things that clinicians are used to seeing to sort of guide decision-making. And then for this project, we had to rely on whatever responses were available in the data set. So these are relatively inclusive case definitions. And then as in any machine learning technique, there's always a potential for overfitting of the data. And this invokes the issue of a variance to bias trade-off in machine learning. So our next steps are actually Dr. Sharon has a number of several hundred patients at UCSF, and we're going to validate our case definitions based on known dizziness diagnoses to see sort of how good that is. And then from there, compare it to multivariate analyses to get a sense for how good these models are. So I'd like to thank my co-authors and thank you for your time, and I'm happy to take any questions at the end. Thanks.
Good afternoon, everyone. I'm Chihiro Yagi from Niigata University in Japan. In this presentation, I'd like to talk about a valuable test in the diagnosis persistent postural-perceptual dizziness, PPPD. There are no relationships to disclose. My presentation consists of 3 topics. First, I'll give a short introduction of PPPD. Second, I'll talk about head roll tilt subjective visual vertical, head tilt SVV. That is a useful test for the function of gravity perception pathway. Then I'd like to focus on the validity of the head tilt SVV in diagnosing PPPD. PPPD is characterized by persistent vestibular syndrome lasting more than 3 months. Vestibular symptoms are exacerbated by upright posture walking, active or passive motion, and exposure to moving or complex visual stimuli. No specific laboratory test for PPPD is available. The SVV is a psychophysical paradigm used for measuring the visually perceived direction of the gravitational vertical using a visual line stimulus. In this figure, the SVV is 7 degrees. This is to say that the conventional head upright SVV is 7 degrees. The head tilt SVV is a test that evaluates SVV during head roll tilt in addition to upright SVV. For example, if the head roll tilt angle HTA is 30 degrees and the head tilt SPV at the time is -9 degrees, the head tilt perception HTP, that is the angle at which the participant feels he or she is tilting, is 39 degrees. At this time, the ratio of the HTP to the HTA is called the head tilt perception gain, HTPG. In this case, HTPG is 39 over 30, which is 1.3. This means that if the HTPG is greater than 1.0, the participant felt and recorded head tilt angle than the actual one. That is overestimation. This is a picture of the head tilt SPV. In practice, it's done in total darkness. Participants wear goggles equipped with gyro sensors that measure the angle of the head tilt and hold the remote control. This is a bar display box, and the bar looks like these pictures. And participants use a remote control to change the angle of the bar and adjust it to the vertical position. We hypothesized that the head tilt SPV could be a clinical measure for the assessment of perceptual hypersensitivity in PPPD that may differentiate it between PPPD and other chronic vestibular diseases. Therefore, we examined the validity of head tilt SPV in diagnosing PPPD. This study included 61 patients with PPPD, 10 patients with unilateral vestibular hyperfunction, UVH, and 11 patients with psychogenic dizziness, PD, who had visited our hospital with complaints of chronic dizziness lasting more than 3 months, and in whom the head tilt SPV was assessed between October 2018 and August 2020. There were no patient selection criteria. The head tilt SPV by thermal caloric testing, vamp, and posturography were conducted on the patients. As for the methods, the Kruskal-Wallis test followed by the post-hoc Dan-Bonferroni test were performed to compare the upright SPV, mean HTPG, and the results of vestibular tests among the 3 groups. The HTPG is calculated for the right and the left head tilts respectively. So the mean of the right and left HTPGs was defined as the HTPG value. Then a receiver operating characteristic curve was created to predict PPPD using the mean HTPG. This slide shows the results of the Kruskal-Wallis test. The significant differences in mean HTPG and canal paresis were demonstrated. The Dan-Bonferroni test revealed that the mean HTPG was significantly greater in the PPPD group than in the UVH and PD groups. The UVH group had the highest CP compared to the other 2 groups. However, there was no significant difference between the PPPD and PD groups. And finally, we calculated the area under the curve, AUC, of the ROC curve to predict PPPD using the mean HTPG. In general, the higher the AUC, the better the predictive and diagnostic ability of the test, and the AUC in this study was 0.764, indicating moderate accuracy. And the mean HTPG of 1.202 has the best sensitivity and specificity for the diagnosing PPPD. In summary, in PPPD group, the upright SPV is within normal limits. However, the HTPG tends to be greater than in other chronic vestibular diseases. The greater HTPG in patients with PPPD could be due to hypersensitivity to the head roll tilt or neck somatosensory stimulation. This is a conclusion. Thank you for your attention.
Good afternoon. My name is Susan Elsperman, and I'm a 4th-year resident at the University of Michigan. Today, I'll be discussing intraoperative electrocochleography during SSCD repair and associated symptom improvement. I have no disclosures. We use electrocochleography as part of our evaluation for patients with suspected SSCD. As a refresher, ECOG is the measurement of cochlear electric potentials generated in response to an acoustic stimulus. Our institution has previously demonstrated that summating potential to action potential ratios are elevated in patients with SSCD, and that intraoperative measurements can be used to confirm the presence of a dehiscence and satisfactory closure, as described by Arts et al. In 2009, from which this image was taken, and Adams et al. In 2011. Examples of intraoperative tracings are shown here. Typically before incision, the SP-AP ratio is elevated and similar to the value obtained during outpatient testing. In this first panel, the ratio is elevated to 0.41, just above a normal value of 0.4. Once the dehiscence is identified and uncovered, the SP-AP ratio increases. Here in the center panel, the value reached 0.58. Once repaired, the value generally normalizes to below 0.4. Here it dropped to 0.11. Based on this pattern, we sought to answer 3 clinical questions. Does normalization on intraoperative ECOG correlate with postoperative symptom improvement? Does the surgical approach matter? And do patients with a migraine history have different outcomes than those without? To answer those questions, we performed a retrospective review of patients who underwent SSCD repair at our institution. There were 46 patients and 52 years included. There was no difference between the 2 groups in gender or laterality. The middle fossa group was significantly younger than the transmastoid group, however. We typically do not offer a middle fossa approach to patients over 65. The outcomes we evaluated were symptom improvement, ECOG normalization, and dizziness handicap inventory scores. We split symptoms into auditory symptoms such as autophony and pulsatile tinnitus, and vestibular symptoms such as pressure or noise-induced vertigo. DHI is not a perfect test, as scores are influenced by mental health, quality of life, and other factors, which makes comparison between individuals difficult. A recent publication by Graham et al., for example, demonstrated that high DHI scores are correlated with functional or psychological diagnoses. There is a high test-retest reliability for individuals over time, though, which makes it a useful metric for us. The average preoperative SP-AP ratio was elevated above normal in both groups. After repair, the mean ratio improved to less than 0.4 for both groups, 0.33 for the middle fossa group and 0.30 for the transmastoid group. There were no differences between the 2 groups. 87% of our patients reported an improvement in auditory symptoms, and 52% reported an improvement in vestibular symptoms. Only 52% of patients reporting improvement in their vestibular symptoms sounds low. This is because we split our patients into 3 groups. Group 1 included those whose symptoms improved. Group 2 were those whose vestibular symptoms were stable, but they had the procedure for bothersome auditory symptoms, or vice versa. And Group 3, those whose symptoms worsened. These categories are shown in the graph. Vestibular symptoms are shown on the left, and auditory symptoms are shown on the right. The middle fossa group is in gray, and the transmastoid group is in white. For both auditory and vestibular symptom improvement, there were no differences between the 2 groups. Overall, 98% of patients had improvement or stability in their auditory symptoms, and 90% of patients had improvement or stability in vestibular symptoms. We also compared patients with and without a history of migraine. We know there is overlap in the symptoms of vestibular migraine and SSCD. Anecdotally, we noticed that some of our patients with migraines had prolonged and difficult recoveries, and thus we wanted to compare results between these 2 groups. Again, vestibular symptoms are shown on the left, and auditory symptoms are shown on the right. Patients with a history of migraine are shown in gray. Patients without a migraine history are shown in white. There was a significant difference in vestibular symptom improvement between the 2 groups. Patients with a history of migraine were less likely to have vestibular symptom improvement than patients without migraine. The difference in auditory symptom improvement was not significant in this cohort. Overall, ECOG normalization occurred in 77% of patients. The relationship between ECOG normalization and postoperative symptom improvement was assessed with a binomial logistic regression. Normalization was correlated to both auditory and vestibular symptom improvement, with significant p-values as shown here. Although fewer patients reported an improvement in their vestibular symptoms, there was a stronger correlation between ECOG normalization and vestibular symptom improvement than auditory symptom improvement. There were no differences in DHI scores between the middle fossa and transmastoid groups. We did find differences between the migraine and no migraine groups, though, which are shown here. DHI scores were collected preoperatively at vestibular therapy appointments and postoperatively. There were no differences between the 2 groups preoperatively. At the first postoperative visit, which occurred an average of 0.7 months post-op, DHI scores were significantly higher in the migraine group than the no migraine group. Patients had a variable number of postoperative visits depending on their recovery trajectory. By the time of the final physical therapy visit, there was no longer a significant difference between the 2 groups, and scores were lower than the preoperative baseline for both groups. These results are biased by the fact that patients who performed well following surgery likely only had 1 postoperative physical therapy visit, so these final scores are skewed towards those who had prolonged or less than ideal recoveries. In summary, electrocochleography normalization correlates to postoperative symptom improvement in our cohort. We will continue to advocate for its use intraoperatively to confirm successful canal occlusion and procedure success. There was no difference between the middle fossa and transmastoid groups in regards to symptom improvement. Patients with a migraine history may experience a prolonged recovery or poor symptom improvement. Additional preoperative counseling should be provided for migraine patients. The study does not investigate why this is the case, but it may be that their vestibular symptoms were attributable to their migraine diagnosis and not SSCD, and thus were not addressed by surgery, or that the surgical intervention itself could exacerbate or trigger symptoms in those susceptible to migraine. I'd like to thank my co-authors, Dr. Kalani, Dr. Tellian, and Dr. Welch, as well as the ANS for this opportunity, and I look forward to your questions and comments.
All right, well, first I'd like to thank all our speakers for an absolutely fantastic session. We're running just a few minutes behind, so we're going to have a discussion. We're going to do it democratically, so the questions that got the most votes are going to be the ones we ask, and we'll get through as many of them as we can. So first for Dr. Slater, Dr. Cass was hoping you could expand on your ideas as to why sigmoid sinus decompression should help with idiopathic pulsatile tinnitus.
The thought process is that the area where it's compressing the flow is against the bony obstruction in the sigmoid itself. And once you remove that bony structure, then just like if you have a water hose or something like that, you'll remove the non-laminar turbulent flow. We did a much larger decompression because we wanted to address all possible areas. And currently we're starting to trim that down to a much smaller area of decompression, right at the point where the sigmoid makes a genuine.
Okay. Did patients, were you able to change their pulsatile tinnitus preoperatively by compressing the neck or anything like that? Or this was just purely idiopathic, no clue that it was venous in etiology?
We had a good clue that it was venous. Many of the patients did get changes with the compression. I would say maybe 60% it would eliminate, but many did not. And so, as you know, if you look at some of the research on that, it's a non-specific finding, but it's very confirmatory when you do find it.
Okay. And then the next question from Dr. Breen for Austin Chow. Regarding the studies that were included, we know that carotid atherosclerosis and bruits are common, pulsatile tinnitus is not. Starting with a Doppler in the neck with a bruit is heard, should the workup stop there? Do you risk missing other pathology? So in other words, how, with the included studies, how did they confirm that the carotid atherosclerosis was indeed the cause of the pulsatile tinnitus?
Yeah, that's a great question that our team did discuss during our late review. I think the clinical picture, the patient risk factors will obviously be very important for determining if additional imaging is needed after a positive, high quality Doppler study. So like in the elderly population, atherosclerosis is the most common cause of pulsatile tinnitus. And so increased prevalence increases the positive predictive value in this population. And I think you could be fairly confident in the result. The one paper I did cite that really, speaks to this is from Psy that confirmed 25 out of the 25 diagnoses made with Doppler, and they just did CT angio afterwards to confirm those results. But yes, there needs to be stronger evidence in the literature. I would definitely agree there.
Okay. And then since I got you, we'll do a follow-up question from Dr. Rubenstein. What is the relative risk of complications with the CTA versus an MRA, MRV?
Yeah, great question. The risks are low, and they're fairly similar for both studies, as they're both non-invasive studies compared to like formal angiography. The considerations, I think, are similar for any like CT or MR study. So a CTA would naturally require contrast administration, which may be contraindicated if the patient has an allergy or kidney failure. But yeah, nothing else that really stands out there.
Okay. And then next one, and I apologize, they're moving quickly as the voting happens, but from Dr. Sajati for the study on Odo 313, the question is, what was the placebo that was used for Dr. Maxwell?
We use the vehicle itself, which is kind of an oil-based, not quite it's more like an oil in a gel, but it's just completely inert.
So let me ask a follow-up to that. Is it visually exactly the same as the drug as the carrier with the Odo 313?
Yes, it is.
Okay, and I think we'll have time for one more question. So I see Dr. Shu asking for Dr. Formeister. Great and interesting talk. When you look at the weighted features for the importance in your model, does your group feel like they fall within clinical reasoning for the different diagnoses included? And are there variables that you would have expected to play a role that weren't being used in the model?
Yeah, it's a great question. And thanks to Dr. Shu for that. And I know he's published a few times on this in the past, so I appreciate his work. But yeah, this is kind of a nice gut check in the sense that it does give factor importance. So you can see, in contrast to some of the other more black box analyses where you have no idea what it's rating as important in the model, this does give you that relative importance. But we sort of saw the main themes throughout all of these were just fatigue and prior history of depression and or anxiety treatment. So there were some that were sort of not expected clinically, but the fatigue and the history of depression and anxiety were like overwhelmingly kind of the ones that kept coming up for the different diagnoses. And these are liberal case definitions because we're again limited by whatever they decided to include in the balance and dizziness supplement. So there was a fair amount of overlap between, dizziness subtypes, which is what you might expect in, given how much overlap there is between vestibular migraine and Meniere's disease, for example. But yeah, it seemed like fatigue and sort of functional limitations in terms of have you stopped doing what you normally would do because of this, and then anxiety or depression treatment. Those were the ones that kept coming up.
Well, thanks to everyone for a fantastic session. Excellent work.